welcome back for another exciting case discussion. We hope you all enjoyed our last episode and will continue to join us for more cool and challenging cases.
Yeah, excited to be back. Ansa, thanks for being back. As you all know by now, you can follow us on our website, poempeeps.com, or on Twitter. And this case, like all our other cases, is not meant for medical advice. Some of the details have been changed to be HIPAA compliant, and the views that we're expressing are not those of our employers, but those of us, which we think is pretty important anyway. Monty, how you doing? Excited for our next case?
Hey, Furf. Yeah, super excited. And Ansa, great to have you back to join the trio. So excited for you to get started with this.
Yeah, super excited for the Poem Peeps to be all together again. So why don't we just dive right into this case? So our chief complaint for today's case is shortness of breath. So we have a 57-year-old man, has a history of hypertension and asthma. He presents with dyspnea and left-sided pleuritic chest pain that has been going on for 3 weeks. He was in his usual state of health up until about 3 weeks prior to this admission when he developed some dyspnea and sharp left-sided chest pain that worsens with deep breathing. His symptoms do accompany an unintentional 30-pound weight loss over the past several months, as well as intermittent cough that is nonproductive. David Monty, what else would you like to know about this patient?
I mean, already this is like really interesting. You have a gentleman, he's 57 years old, a little bit older, we'll say middle-aged, hypertension, some asthma, and then 3 weeks of dyspnea, and then left-sided pleuritic chest pain. So localized to one side, and it's chest pain, it's pleuritic. It definitely helps me sort of narrow my differential. So right away, I think you have to think about PE, and anybody who is like this, you maybe had a PE in the past and it's just been going on. Now you could have a pulmonary infarct that's causing the ongoing pain. I really worry about in patients like this who are like previously healthy and not in the medical system that much, having a pneumonia, like a community acquired pneumonia, went undiagnosed, maybe they tried to shake it off, and then it presented or progressed to an empyema and a pleural effusion, and now you're getting pleural irritation. I've seen a number of people even younger than this, just sometimes young gentlemen in their 20s and 30s who try to ignore an infection like this, and then they get a big whomping empyema that can cause this type of pain. It's curious in these cases to lay out the dyspnea and then start asking about coughing, because sometimes the chest pain can just be musculoskeletal and can just be from lots of coughing that was going on. And so I like to find out if there was a cough associated with this shortness of breath. And if there was, maybe not just musculoskeletal, but maybe has a pneumothorax, or he came to the hospital because finally the pain got really bad and he popped a pneumo after coughing a lot. Other things to think of, especially with the ongoing chest pain on that side, pericarditis can kind of do it a little bit unusual to have it be presenting without a primary chest pain complaint. But if it's pleuritic and it's in that side, it can definitely do it. Myocarditis sometimes. Somebody who has septic emboli could start having shortness of breath, and then that could end up having a larger lesions in the lung that irritate the pleura and cause the pain. And then with the 3 months of weight loss that he has going along with this, 30 pounds. Now I'm thinking about sort of other causes as well of sort of chronic inflammatory diseases. So malignancy, and then maybe now he has a malignant effusion that's causing the pleuritic pain, or tuberculosis. TB pleuritis is actually the most common way that it presents worldwide. We don't see it a ton in the United States, but it's definitely got to be high in the differential for this person. So all that being said, those are the things I'm thinking about. The things I want to know is, how has this changed in the past few weeks? Did the cough come on at first? Did he have a cough and then that has worsened the chest pain as it's been going on? Does he have positional things with his dyspnea and chest pain? Could that be pericarditis that I mentioned that's playing into it? And then what is his asthma history? I always want to know his past medical history a little bit more. Has he had asthma exacerbations a lot? Could this more acute presentation on top of some chronic underlying lung disease?
Yeah, Furf, that was a great overview, definitely, of some top differentials for that. And I definitely agree with the 30-pound weight loss and a non-productive cough, definitely concern of underlying malignancy or infection. So, Ansa, I know that Furf mentioned a couple of other review systems to ask, but I would just add, in addition to that, any type of fevers, chills, hemoptysis, or any constitutional symptoms. And I wonder, Ansa, if you have any more information about his past medical history and current medications.
Yes. I certainly can add a little bit more information, and that's already a great differential I think that we have going. So we actually, other than the fact that he self reports a history of hypertension, is on medication for that, and reports that he has a history of asthma, we actually don't have any PFDs in our system, so it's sort of a presumed diagnosis, and we don't have a lot more information about that. In terms of his medications, he does take lisinopril 20 milligrams for his blood pressure, and he uses albuterol as needed. And he says he's very infrequently had to use it. In terms of the rest of his history, I think Dave brought up some great points about sort of like TB risk factors and thinking of things like that. So he is actually originally from the Dominican Republic. So he's born outside the U.S. and he does travel back and forth frequently. He's a never smoker, does drink alcohol socially, denies any drug use, and does not report any occupational exposures. About the chronicity of his symptoms, he says that he has had some several months of this intermittent dry cough that sort of seem to precede this left-sided pleuritic chest pain that he's developing now, as well as the shortness of breath that he's experiencing now. He denies any sort of subjective fevers and chills, hemoptysis, and other than the 30-pound weight loss, no other constitutional symptoms.
That's all really great information. I think like the social history, past medical history, family history there doesn't give you a huge revealing factors, but sometimes that's helpful in the absence of revealing factors. So, he has a history of asthma and maybe we don't know that much about it. He doesn't have PFTs, but he's only on albuterol as needed. He hasn't had frequent exacerbations that he knows of or hospitalizations. Probably it's not too severe. He's on lisinopril that can cause a drug cough and a dry cough. And like you were saying, that preceded his symptoms, but pretty unusual to have chest pain or dyspnea with that. And a pneumothorax, just from a mild cough like that, would usually indicate some other underlying lung disease. He's a never smoker, which just helps us with everything. Lots of diseases that he's less at risk for, certain types of ILD, COPD that could be playing a role in this. And then, his born in the Dominican Republic, there is an area with a higher rate of endemic TB. He's traveling back and forth. He has exposures. That's definitely still on my differential with his weight loss and then his ongoing cough. Mostly, I'm struck that he sounds like he's a pretty overall healthy guy, and he must be feeling pretty poorly if he came in now. So, certainly if this person was seeing me in my clinic, I would want a pretty quick workup. And if they were in the ED, I think probably warrants an admission, no matter what they kind of look like, just for sort of expedited eval, because he sounds like he's not doing too great. So my next step would be to just examine him for sure and see what pops up.
Okay, that's great. One interesting sort of thing that I had actually looked into, because we do see a lot of patients who are from the Dominican Republic in sort of our community, and it seems like the overall TB risk factor is probably not that much different than what it is like in the United States for Dominican Republic, believe it or not. And actually, areas such as, like, for example, if it was somewhere else in the Caribbean, like Haiti, which is like much higher risk of like of tuberculosis, almost like as high as like you think of areas such as sub-Saharan Africa or India or like Southeast Asia. So I think it's like definitely a thought for him with the 30-pound weight loss, and definitely was like on my differential when I was like reading about this case.
No, that's totally great, Ansa. And I think that's an important thing that comes up is sometimes we hear a travel history somewhere and we just sort of automatically assume some things. And you're totally right. You have to look up on the CDC website or the WHO website what the rates are of different diseases in different places. And they'll definitely help you maybe think of things you haven't thought of. And I agree. It's not like Dominican Republic is someplace where TB is sort of so prevalent that we see it a lot. It's just probably slightly more than we're seeing in the United States general population. But that's really helpful.
Totally. You said that basically what I was trying to get across a lot more eloquently. So thank you. So, as you suggested, we can go ahead and examine this patient. So, sort of starting with his vitals, he comes in afebrile. He is normal heart rate. His blood pressure is 122 over 78. His breathing, respiratory rate is 18, and he's standing 98% on room air. Generally, he does appear overall pretty well. He's resting comfortably. His head and neck exam is pretty unremarkable. No lymphadenopathy that's sort of noted. His respiratory exam is notable for decreased breath sounds at his left base, and his right lung is clear to auscultation. His abdominal exam is completely unremarkable. On his extremities, he has no edema. He's warm and well perfused. He has no rashes, and his neurological exam is completely normal as well.
Thanks so much, Ansa, for reviewing the physical exam. And just, starting with his vitals, I think those are pretty much reassuring so far. He's not requiring any supplemental oxygen. The respiratory rate is a little bit on the higher side. I know we see a lot of respiratory rates charted, but we have to check ourselves just to make sure that's accurate. And some other things that you mentioned that were good were that, he seems to be comfortable. You didn't specifically say, but assuming from your description, one thing I always like to ask is or assess is whether or not they can speak full sentences without any issues, and it appears that he is. But one thing that really stood out to me was the decreased breath sounds at the left base. And when I think of decreased breath sounds, I think of kind of four large categories or reasons why. And the first one is, is there any increased thickness of the chest wall that may be transmitting the sounds differently and kind of sound more decreased or dull. The second one is there reduced airflow to part of the lung. Three is there overinflation of part of the lung, and sometimes this can happen with severe emphysema or large bullae that are there. And the fourth one is a component of air or fluid surrounding the lung, such as an effusion. And I think a couple of other maneuvers to consider here are really to assess for percussion as well as egophony. So for percussion, this is going to be kind of tapping out and, on both sides to see if there's any difference. But this really helps determine if there's, air, fluid, or a solid component that could be present. And typically, our normal sounds should be what referred to as resonant, but typically when there's air, you'll hear hyperresonance. And while there are solid components, you will hear dullness. So, for example, if I'm concerned about an effusion where I should be hearing air and I'm actually hearing more of a dull component, I may think that there's something that's going on that shouldn't be there. And the second thing is really to assess for egophony, and this is where kind of remembering basic exam skills. You listen with your stethoscope and have the patient say E, and while you're listening to the lung fields, if consolidation is present, the E turns into more of a high-pitched A sound, which again supports an underlying consolidated process.
That's super helpful. And I think sort of like now, full disclosure, a lot of time where we have the chest X-ray available at the same time as when, sometime even before examining the patient, I think like we don't think about this as much, but definitely this is such a good review for myself.
I was just gonna say that I feel like and then now in COVID, throw on the fact that everybody's got layers and layers on and gloves on, and you're not percussing as much. And I think there are people out there who are even more zealots on the physical exam, certainly than I am and than Monty are, like Dr. Garibaldi, who's an absolute pro and can diagnose anything on physical exam. But I think that it's really important to have some level 202 physical exam. Percussion and egophony are pretty easy. It's not like trying to measure a liver span or look for splenomegaly, an exam maneuver that might be a little more difficult, and imaging is just so easy for this. This should be something that we kind of like do all the time if you really have decreased breath sounds there. And then I love the respiratory rate point, Monty. The one thing I always tell people to do, and that I try to do, is I try to breathe the same rate as the patient. And then it's like just really helpful to me. Counting and the numbers, I feel like becomes confusing. But if I just try to match their breathing pace, if it's like an overdose, I'm like, wow, they are not breathing at all. Or if they're breathing 18 times, I'm like, oh, I'm really having to keep up with this. This can't be normal.
Oh, wow. I love that. I'm definitely going to be using that, Dave. So that's great. So why don't we go ahead and review some of the patient's initial labs? Um, So starting with his BMP, pretty much unremarkable. He has a normal, electrolyte panel. His BUN is 16, creatinine is 1.1, which is presumably his baseline. We don't really have any prior labs from him. He has no anion gap. His calcium, mag, and phos are also within normal limit. His CBC, he has normal white count at 4.3. His hemoglobin is 14.4. He has normal crit. His platelet count is normal. He has a normal MCV at 82. His differential is unremarkable. He did have 6.7% EOs, but his absolute eosinophil count is less than 500. It's at 290. His LFTs, he has no transaminitis. He has normal billies, and his total protein 6.9, and his albumin is 4.2. Does not have a protein gap. His alk phos is normal. He also has a normal PTT and INR. So overall, looking at his lab, they're pretty unrevealing and don't really help much, at least to me. What do you guys think about these labs, and what would you like next for this patient?
Yeah, I agree. Not hugely revealing. I think in the same way that the history was, sometimes what's not there can be helpful too. He doesn't have a marked leukocytosis and with no neutrophil predominance. The fact that this would be an acute bacterial pneumonia is much, much less likely in that case. He has a bicarb that's slightly elevated at 27. It could be abnormal in some retention, but it's probably just in the range of normal. We could check it with a blood gas. You mentioned his eosinophil. I agree. The absolute eosinophil count is less than 500. That probably less likely to be a primary eosinophilic disorder. I will say anything above 200, I do keep in mind that you can get organ infiltration and organ damage with that. So it's still very possible that could be related to his underlying asthma. You mentioned that LFT is being normal and albumin actually, which is normal too, which is just interesting in a patient who has a weight loss of 30 pounds. It makes me think that malignancy and, real significant malnutrition is a little bit less likely on the differential. Just something to note. Um, uh, and we don't have anything here that tells us that he has signs of a, chronic inflammatory condition or infection. I would probably want inflammatory markers just to kind of see where he's at ESR and CRP to see what his chronic inflammation has been like.
Great. That's awesome. I want to pull up the chest X-ray next, and I was hoping Monty, you can kind of take us through the chest X-ray.
Yeah, of course, Ansa, and we'll definitely post this so that you can follow along with us. But based on my read, I would consider this an overall good film. The penetration looks appropriate, and I would say overall normal inflation. So normal lung volumes in this patient. So I'm saying that because I see 10 posterior ribs, and remember we want to see 8 to 10 posterior ribs to make sure that it's normal inflation. Um, Going to the airway next, I think that the trachea appears overall midline. I'm not seeing any bony abnormalities. Looking at the heart borders, the right and left cardiac borders are both apparent to me. So I'm not concerned necessarily about cardiomegaly or anything obscuring either the right or left heart border. As far as the right costophrenic angle, there's some, or it appears visible to me, but looking at the left costophrenic angle, I think that there's some blunting, so suggesting possible underlying effusion. And as far as the actual parenchyma itself, there does appear to be some bilateral interstitial markings, more so in, at least looking at this on my screen, more so in the bases than in the upper lobes. And there appears to be some significant bilateral hilar adenopathy.
Thank you so much for walking us through this. And like you said, we'll have this posted for everyone to sort of review with us when they're listening. The patient at this point, we get a bit more information about this infusion, as you pointed out, and there seems to be some chronicity to this. So the patient says that about a few months ago, he was actually traveling to the DR, and he had sort of similar symptoms of cough and some left-sided a pleuritic chest pain. And he went to the hospital and was treated with some antibiotics and was told that he had fluid in his lungs, which was removed. So, presuming that he had a thoracentesis at this time. We unfortunately don't have any other data from that visit and sort of what was thought to be the etiology of this effusion.
That's really helpful information, Ansa. And I think, definitely trying to get as much history as we can from this patient is important. And, specifically in this, determining, what side was the fluid removed from. If it's his left, we can think it's more of a recurrent effusion. If it was on the right, that may make also change our differential as well. So definitely want to try to get that. As part of the next point of workup for him, I definitely want to get a CT chest to better characterize the lymphadenopathy that we see on his chest x-ray. In addition to better defining the parenchymal findings that we saw, as well as confirm the presence of the left pleural effusion that was suggested on his x-ray.
So the patient actually gets a chest CT next, and we'll have these images available for everyone to review with us. And I'm just going to go through sort of some of the notable findings that there were, and there were quite a lot. So the most notable thing on the chest CT was diffuse mediastinal and bilateral hilar adenopathy, which was definitely intrigued by interest. And then, as well as they characterized the left-sided pleural effusion we're seeing on the chest X-ray as moderate and with likely pleural implants as well. He has a 1.1 centimeter nodule in his right upper lobe, as well as some nodular septal thickening in the lungs bilaterally, which was suggestive of, to the radiologist, lymphangitic carcinomatosis. Additionally, he has like many other findings, incidental findings, including multi-level paravertebral soft tissue densities along his mid-thoracic spine. And it doesn't end there. There's more. They also noted this large lipomatous lesion in his lower pelvis, and it seemed to be impinging on the bladder and displacing it posteriorly. And given the location, there was some concern that this could be a low-grade liposarcoma. So, in addition to the chest CT, he also this like the findings sort of that I was reading, where it was a chest CT as well as a CT abdomen pelvis. So they weren't seeing the pelvic lesion on his chest CT. I didn't mean to make that impression. And in addition, on his CT abdomen pelvis, he had lymphadenopathy, sort of diffusely, but most noticeable in his paraceliac and portahepatis region. So there's obviously a lot going on with this chest CT and gives us a lot more information, as well as the CT of his abdomen and pelvis. And especially I thought the diffuse, very pronounced lymphadenopathy was interesting. Dave, what do you make?
Yeah, that's certainly quite the CAT scan and read that we have there. In these situations, I do like to take a step back at this point and sort of just summarize where I'm at to give my thoughts in line. So this is a 57-year-old man, relatively healthy, past medical history of hypertension and mild asthma, who's been traveling back and forth in the Dominican Republic and presents with 3 weeks of dyspnea and left-sided pleuritic chest pain in the setting of a more chronic dry cough and 30 pounds of weight loss. He has a physical exam notable for relatively normal vital signs, mild tachypnea, and findings possibly consistent with the pleural effusion, and laboratory evaluation that's pretty normal on basic CBC, CMP, BMP. His imaging then reveals a left-sided pleural effusion and diffuse lymphadenopathy, also pleural implants, and then multiple other findings, sort of soft tissue densities along his spine, and some findings in his abdomen and pelvis that we have to work through. So taking that, we have a patient here. He's had lymphadenopathy. He's had weight loss. Now a recurrent pleural effusion. And all of this is, pretty extremely important to thinking about his case. So right now, his differential is really broad. We don't know that much about this guy yet. It makes me interested about what his underlying immune status is. And I would sort of put his differential into 3 broad categories at this point based on the lymphadenopathy and these symptoms. So the first is infection. He could have a systemic infection leading to lymph node response throughout his body or leading to a recurrent pleural effusion. Things like tuberculosis, things like endemic fungal infections, histoplasmosis could do this, or viral infections. He could have HIV as an underlying diagnosis, which would cause diffuse lymphadenopathy, and then a superimposed infection on top of it. He had CMV, EBV. If you were immunosuppressed and there's some reason we don't know about this, then these things could cause sort of this type of reaction as well. The other broad category would be malignancy for sure. Lymphoma absolutely could present this way. Lymphoproliferative diseases definitely can have this indolent onset where he's going forward. And then now he's progressed to having a pleural effusion, and that's what brought him in. Also, inflammatory conditions, connective tissue diseases, and rheumatologic diseases could definitely do the same thing. Sarcoidosis can cause lymphadenopathy all over. Effusions are a little unusual, like unilateral effusions in sarcoid, but possible. Lupus, RA can have these types of manifestations. And then I think there are these rarer primary sort of lymphadenopathy diseases, Castleman's disease, Kikuchi disease, that can cause a presentation like this. So, I think his differential right now is really broad. And now we have to start thinking about what labs can we get and what tissue can we start targeting to give us a little bit more in.
Great. That was such a great differential for him. So I think we need a little bit more information to help us narrow our differential. So as a next step for him, Monty, do you think he should undergo a thoracentesis?
Thanks, Sansa. Yeah, I definitely think so. This is I'm considering him as a new case to us. We don't have any prior imaging, and I know that he said he had drainage before, but we don't have any records of that. So I am considering this to be somewhat of a new effusion, and I would say an overall, based on imaging, a new moderate sized pleural effusion in a patient presenting with weight loss and cough, and definitely doing a diagnostic thoracentesis to help determine the etiology and a unilateral effusion is important. And as Dave mentioned, there's a super broad differential at this time. The two things that I'm thinking of right now are infection as well as malignancy.
Okay, excellent. So I guess just thinking about pleural effusion for this patient, we can quickly review sort of, how we approach our differential for a pleural effusion. And I think of it in two large buckets, transudative and exudative. And like you said, the thoracentesis and fluid studies are going to be extremely helpful in making that diagnosis. So, sort of the common, causes of transudative effusion that we think of are heart failure, liver disease, ESRD, nephrotic syndrome. Whereas for exudative, we're thinking more of infection, cancer, and autoimmune processes as well. Sort of thinking of more rare causes, Dave and Monty, like, which I'm sure you guys have seen through your experiences, like chylothorax, et cetera. Does that commonly present as an exudative effusion or transudative?
Yeah, that's usually presented as an exudative effusion. And I think when you're getting into some of those more rare etiologies, then you're starting looking at cell counts and then some of the more esoteric labs that you can send on the pleural fluid, like triglycerides and cholesterol levels to help you with that. But I think the common ones, like the transudative and exudative, like you mentioned, at least we just need the pleural protein, serum protein, pleural LDH, and serum LDH so we can do a basic analysis of it.
That's awesome. And do you ever sort of like think about like, unilateral sort of like the laterality, if it's right-sided versus left-sided, and sort of makes you think of like certain diagnoses as or like certain
Yeah, I definitely think. I mean, I know we were recently consulted on someone with underlying liver failure with a hepatic hydrothorax. So, definitely, more so occurring on the right side. And, one thing that I also think of more so for the left side, though, typically the classic teaching is more so pancreatitis or potentially esophageal rupture. And you brought up an interesting point about the chylothorax. We recently saw that a couple of weeks ago too, and there's some differences on what side that occurs on. We actually saw it on the left though. And to answer the question, yeah, it was transudative, but it was exudative, but chylothorax can be exudative just based on protein and not LDH. So lots of things to talk about with pleural effusions for sure.
Patient does undergo a diagnostic thoracentesis, and we have the results that I want to go over with you. And then I'm hoping that Dave, you'll be able to help us sort of interpret these. So his pleural protein is 5.6, and his pleural LDH is 162. His serum protein is 6.9, as we reviewed earlier, and his serum LDH is 189. And his pleural glucose was 114. He did have 4,000 RBCs, and he had 3,000 nucleated cells, 2% PMN, 65% lymphocytes, and 17% EOs. So, Dave, if you can sort of walk us through, do you think this is an exudative or transudative effusion based on the Lights criteria, and what you make of the rest of the studies?
Definitely. So you mentioned it. Lights criteria is what we use to look for transudative versus exudative. These were discovered clinically and described by Dr. Light, and there have been multiple other studies going forward about trying to use other metrics, but this is still the best one that we have for transudate and exudate. So to review, Light's criteria is that first we look at pleural protein over the serum protein, and if it's greater than 0.5 is the number we care about. And then we look at pleural LDH, and we care about two things there. Is the pleural LDH over the serum LDH ratio greater than 0.6, or is the pleural LDH greater than 2/3 the upper limit normal of the serum LDH cutoff at your lab or hospital? And all you have to do is meet one of these criteria, and you have an exudative effusion. It increases your probability. So for this patient, they are meeting all three of these criteria. So pleural fluid LDH over serum LDH is greater than 0.6 and higher than 2/3 the upper limit of normal, and the protein is higher than 0.5. So I think this is an exudative effusion. The next things that I think you should always send when doing a thoracentesis and analyze a pleural effusion, really important to send pH. I think if there's a concern for infection, you can diagnose empyema just on pH alone. So pH less than 7.2, at least being a complex parapneumonic effusion, and the lower that pH being, more concern for an empyema. Lower than 7, I get very concerned. In a chronic effusion, that can be a little bit lower if the fluid's just been sitting there, but it's very helpful. So his pH was 7.45, and it makes me less concerned that there's a active empyema in there. And then you mentioned the glucose. That's helpful as well. His glucose was got to be considered relative to his serum, but it was 114, likely pretty normal. In a patient who has had a very chronic effusion or infected pleural space, that glucose level may be lower. And then finally, I always want to look at the cell count. So you mentioned the percentage of nucleated cells. He has a lymphocytic predominant effusion, 65% lymphocytes. This is helpful for a variety of reasons, kind of looking through what our underlying etiologies are. So, first of all, if it's going to be an empyema, infected bacterial infection in the pleural space, you usually think of a PMN predominance. Lymphocytes can be present in malignancy, they're sort of the most common presenting dominant cell type. Also in inflammatory conditions like lupus or RA that are causing a pleural effusion there. Eosinophilia can be helpful. They can be from prior eosinophilic disorder, but also just trauma and pleural irritation can lead to an eosinophilia in the pleural space. So it's something we consider, but definitely looking at the differential is helpful going forward. So he has a lymphocytic predominant exudative effusion. I think that, while infection was still on our differential, an acute pneumonia and bacterial infection is a little bit lower. Things that I'm thinking about for him with his lymphadenopathy we know of as well, certainly malignancy could still be very high up in this. I want to send this fluid for cytology to see if they can identify any cells that are concerning for cancer. Highly lymphocytic pleural effusions can also be due to tuberculosis, which is still our differential. We have some other tests we can send in the pleural fluid to try to get at that. One they talk about is ADA, although it's probably a pretty tricky test to interpret, and the best is just to send the fluid for AFB smear and grow it out in culture. Other things that can cause a highly lymphocytic predominant effusion are sarcoidosis. Again, it's rare in sarcoid to have this, but it can be to do it. Rheumatoid arthritis. And then you talked about chylothorax. That's usually a lymphocytic predominant as well. So I think for this patient, I would definitely send this fluid for cytology. You could even send it for flow cytometry if there's a high concern for lymphoma, and in his case is probably right. And I think that without the fluid appearing like white or milky, a chylothorax is pretty less likely and a little bit less likely to explain his lymphadenopathy, although it can happen in systemic disorders. So we could send a triglycerides and a cholesterol level just to sort of to rule it all out. But yeah, I think this was super helpful. And with these further tests coming in cultures, we should get some more information.
This is super helpful. So, very interesting about the pH sort of cutoff. So, what you mentioned earlier, I thought was interesting. So, if the pleural fluid has been sitting out for a while and the pH returns really low, I guess it sort of could mislead you. Is that correct?
I think that is always this thing that comes with like with pH tests, like it's like, oh, did the fluid sit out and where did it go? I would say that if you see a thing of low pH in pleural fluid, I would treat it as real. The concern is if it's been a chronic effusion for a long, long time, the pH could be low because the cells have been in there and dying. But I would say that if there's concern and you have a pH less than 7.2, I would treat it as a complex parapneumonic effusion.
One other interesting thing that sort of caught my attention was the pleural eosinophilia. Monty, I was wondering if you can comment on that.
Yeah, definitely. And I will admit also that that's not something that I have typically seen in the pleural fluid studies that I have done, but definitely something I think worth talking about briefly. Um, Eosinophilic pleural effusion is typically defined as a pleural effusion that contains more than 10% eosinophils. And really looking into this, it's only accounts for about 5 to 10% of pleural effusions total. And Furf already briefly mentioned, one of the causes or conditions that can result in a eosinophilic pleural effusion is introduction of air in our blood into the pleural space. So pneumothorax itself, or post-thoracic surgeries, or even simply performing a thoracentesis itself has been thought to be possible causes. Again, with everything and kind of the theme with this patient, there could be a lot of different reasons why he may have this, but some other things that are coming to mind, specifically, still high on our differential for him is malignancy, infections, which can be both bacterial, fungal, or even parasitic, pleural irritation or trauma, as we mentioned, broad category of autoimmune disease, acute or chronic eosinophilic pneumonia. Definitely can also be drug related. And the three drugs that I try to remember with this are warfarin, nitrofurantoin, as well as fluoxetine. And then the other one that I remember is another reason why is a pulmonary embolism or PE.
It's very interesting. So I guess sort of rounding out additional data for this patient, he does sort of get like some of the additional tests that Davey had mentioned. On his pleural, fluid was sent for cytology and is negative for any malignant cell, as well as flow cytometry that was also negative. So at this point, sort of running out some additional data that he had some workup sent for the endemic fungi. So he had histoplasma urine antigen that was sent that was negative. He had blasto and coccidioides antibodies that were sent that were also negative. His fungitel was less than 31, which is negative per our lab. And he also had an aspergillus galactomannan sent that was negative as well. So it sort of a lot of the data starts coming back and not revealing of much at this time. So what should be our next step from here?
Yeah, so now he's had sort of a broader workup for inflammatory infectious conditions. We've gone to the pleural fluid and not got an answer. I think he probably warrants a little bit more workup for his connective tissue disorder or potential rheumatologic diseases. At least an ANA, maybe some complement levels, and starting to see if he has any antibodies that pop up. But short of that, I think, tissue is the issue as it goes, right? So he has a recurrent pleural effusion. He has pleural nodules seen on scan. That can't be normal and is probably the reason for it. And then he has this diffuse lymphadenopathy. So whatever we can get access to tissue, I think we probably should.
And sort of as you mentioned, tissue is what we want. And at this point, the patient is evaluated again by the pulmonary team, and he undergoes a bronchoscopy with endobronchial ultrasound, and it shows no malignant cells. And he also does get a transbronchial FNA of his left hilar lymph node, and the pathology on that was interesting, and it was noted to have granulomas on the biopsy. So, which is like a very interesting development at this point for this patient. And Monty, how does that change our differential or narrow our differential among the many things that we discussed for this patient?
Yeah, I mean, I think that is helpful in certain aspects, because there's still a broad category for granulomatous disease, and if you can, I don't think it was mentioned, but were these caseating or non-caseating granulomas? I think is important to understand when we have that data as well. But thinking of granulomatous disease, Furf has already mentioned TB, so I think that's definitely still there. Sarcoidosis, again, is high on the differential. Histoplasmosis as well as blastomycosis are as well. I'm still thinking, Hodgkin's lymphoma can still be there, as well as rheumatoid arthritis.
Great. That's a great differential for sort of like the path findings for this biopsy. So as I reviewed earlier, a lot of the serology for the endemic fungi, including blastomycosis, were all negative. He had a negative RPR. He also had autoimmune workups, and including ANA and ANCAs, which were all negative as well. And given this diffuse lymphadenopathy, the 30-pound weight loss, and sort of this pelvic mass that was seen on imaging, I think there was very high suspicion for a malignancy. So the patient did undergo a PET CT and had sort of very multiple sort of FDG avid lymphadenopathy, which was noted. And at this point, sort of like I think heightened the sort of concern for a malignant process for this patient. And at this point, sort of what would you recommend for?
So I like to take, again, a step back for a patient like this. So 57-year-old man, pleuritic chest pain and dyspnea, found to have diffuse FDG avid lymphadenopathy with pleural studding and recurrent pleural effusion, and a lymph node biopsy showing granulomas. So our differential is definitely narrowed significantly. I think he's at a really good infectious workup, and we don't see anything. So I think we can put those aside at this point. He also has had a pretty good serologic workup for connective tissue diseases or immunologic disorders, and all of that seems negative. So even though these could all be consistent, no evidence of that right now. I think malignancy still has to be number 1, 2, and 3, given the FDG avidity and that it's a can't miss diagnosis, and that those can cause granulomas as well. But we also have to think about sarcoid. It's a benign granulomatous disorder. Effusions are a little unusual, like we talked about, but he has pleural studding, and it can definitely cause diffuse lymphadenopathy like this. I would not hang my hat on sarcoid, even though the biopsy would be consistent with it right now. Given that he has so much avidity, I would really want to rule out malignancy. And then finally, even though the AFB has been negative so far, TB can be a really sneaky organism, and it can be hard to make the diagnosis. So I think right now I'm down to diffuse malignancy, really lymphoma is what I'm worried about. TB that we've not been able to diagnose, and sarcoidosis as the differential for this. So I would want to get more tissue. I know we already have some, but I think it's time for him to have a larger biopsy and not just a sampling. And so I would see what the most accessible lymph node he could have was, maybe a mediastinoscopy to biopsy at least one, if not a couple lymph nodes, and see if we can make a diagnosis. Could go after the pleural implants too, but it's probably a little bit harder to get.
And that's exactly what's done for this patient next. Actually, he does go mediastinoscopy and biopsy, and of one of these hilar lymph nodes actually, and here's the path result. So there's extensive non-necrotizing granulomatous inflammation, which is highly suggestive of sarcoidosis. His AFB and gram stains are completely negative again for sort of like the cultures, and his flow cytometry and was again also negative, and no cells, abnormal cells concerning for a neoplasm. And ultimately, the path was thought to be most consistent with sarcoids.
Cool. Sarcoid. This is the great mimicker and the thing that comes up all the time. I mean, I think these are the cases that are always a little anxiety provoking. You want to rule out all these things, but now you've gotten tissue multiple times and we have sarcoidosis. So, what is sarcoidosis? It's a granulomatous disease. We don't know all that much about the underlying etiology. We know it's immune mediated and then you get these granulomas, most commonly in the lungs and the pulmonary lymphatic tissue, but it can be anywhere in the body. It usually presents in young people, typically between ages of 20 and 60, and approximately 10 years earlier in African Americans than in white Americans in the United States who present with it. It can affect anywhere in the body, but the most common presentation is bilateral hilar adenopathy. And often this is asymptomatic. It's just something that's seen on imaging. And women are twice as likely as men to have this diagnosis. About 30% of the time, it presents with extrathoracic manifestations of sarcoid, and the most common ones outside of the lungs are skin, joint, and eye lesions. And the classic rash that you'll hear about on boards is sort of this very tender rash on the shins, erythema nodosum. But respiratory symptoms are the most common, non-specific cough, shortness of breath, sometimes chest pain if you have sort of bulky disease, a little rarely. And we're going to talk a little bit more about the treatment, but we want to think about the extent of disease when we have it. And like we talked about, everybody who has sarcoid needs a little bit of rule out or for other factors. So everyone needs to have TB testing. And then aside from that, we want to evaluate for any disease process that they may have. Aside from that, we also want to see the extent of disease they have. So everybody who has a sarcoid diagnosis needs at least a CAT scan, PFTs, an EKG because they can get cardiac involvement, an eye exam, and then monitoring of their blood counts as well as vitamin D and
I
calcium.
thought very interesting the initial presentation with the pleural effusion. Is that very common? Do you see that a lot?
No, it's definitely rare. I mean, it's not even on my differential for like a unilateral pleural effusion. I guess it's on the differential, but it's really low. It's very unusual for sarcoid to present that way. That being said, you have tissue that shows it. That's going to be it. We could confirm it with a pleural biopsy, but it's rare, but not unheard of. Monty, have you seen it before?
Yeah, I've seen one case, but I definitely agree it's rare. And I know in one of our other cases, we brought up Dr. Peter Terry, who's one of our senior faculty at Hopkins, and he has always said that just be just to include broad differentials when you do see an effusion, just because you want to rule out everything else before saying that it's sarcoid. So per his suggestion as well, it's something that is not typically seen, but there are some cases where that has been noted.
One other sort of, I think that's invoked a lot in the question that comes up all the time is the question of serum ACE levels and how helpful they really are. Monty, how do you sort of approach that question and how helpful do you find them?
Yeah, honestly, I think the ACE levels
It
kind of
is
take me
indeed.
back to step one. I remember studying for it, and this was always coming
The
up.
golden age of
Yes,
step one, your favorite time.
yeah. So ACE level, our angiotensin converting enzyme, is it's basically when I remember learning it's a serum marker used in sarcoid, and on step it would always say derived from epithelioid cells from activated macrophages, and while ACE levels they basically correlate with the amount of whole body granulomas, so not just necessarily the ones found in the lungs, but everywhere, and disease severity. But it's important to note that it can also be elevated in other non-sarcoid conditions as well. So some of the ones that we've talked about include tuberculosis, um, coccidiomycosis, as well as silicosis, and even hyperthyroidism is one that I remember hearing. So overall, it's a marker for that's used in sarcoid, but it doesn't have the greatest sensitivity or specificity either. So while an elevated level may be helpful for overall disease burden, you have to look at the entire clinical picture.
That's super helpful. So I guess my takeaway is that it can be elevated in many of the different granulomatous processes. So if you're trying to differentiate among several of them, this may not be the most helpful test.
That's exactly right.
Okay, awesome. So I guess I wonder then, what is the diagnostic test for sarcoid, or does one exist?
That's a great question. And yeah, to my knowledge, one does not exist. And there's actually a great kind of publication from the American Thoracic Society that was published in 2020, where they talk about the diagnosis and detection of sarcoid. And really, per this guideline, I remember three things from it. And while there's not a definitive diagnostic test for sarcoid, you really want to look at three key elements when you're diagnosing someone. And the first one, is there a compatible clinical presentation? So this is not only supported by imaging, but also physical exam. The second is the detection of non-necrotizing granulomatous inflammation in one or more tissue samples. While this sometimes can be primarily from the lungs, and like our patient that had EBUS and then mediastinoscopy, you can also do sometimes more of a cutaneous sample as well if someone's presenting with rash, as Furf mentioned earlier. And really, the third part of this is what we've done for this patient, and definitely exclusion of other diseases that may present similarly. So, overall, to answer your question, no definitive diagnostic test, but those three key parameters that we try to look at.
Speaking of step one, actually, I was just thinking it reminded me of sort of like a step one or U world question must have done sort of this like triad of symptoms that you see, and sometime if that's your acute presentation, it's consistent with sarcoids that you don't need a clinical diagnosis. Maybe Dave Ramon, do you remember what I'm talking about? It's like at the tip of my tongue. It's like when you have the skin finding of erythema nodosum, fever, and I think bilateral hilar lymphadenopathy, that it's like diagnostic of sarcoids. Am I making that up?
Yeah, no, you're not making it up at all. One of the presentations that sometimes gets quoted a lot is this Lofgren syndrome, that where you have swollen lymph nodes in the chest, lymphadenopathy, you have erythema nodosum on your shins, and then a fever and some arthritis. And actually, it has a pretty good prognosis. Lofgren syndrome often is not something that leads to long-term severe sarcoid. It usually recedes in response to treatment well. So, yeah, Lofgren syndrome could be our eponym for the day.
Love it. And I also do remember, speaking of step one and taking me back to med school, learning about sort of radiological stages of sarcoids. Dave, can you talk a little bit about that?
Yeah, definitely. This comes up a lot. I think it's important to remember that these are not stages that everybody sort of progresses through. It's usually a method that we use to sort of characterize the amount of disease that they have, but it's not like everyone goes from 0 to 1 to 2 to 3 to 4. So 0 is just a normal chest x-ray. 1 is like this patient, if he didn't have the effusion, just bilateral hilar adenopathy and mediastinal lymph node enlargement. So this is the most common presentation, and we'll talk about treatment in a second, but this is a good prognosis. A lot of these patients, about 75 to 80% of people who just have stage 1 disease are not going to ever require treatment for their sarcoid. It's a disease that can often burn out, and it may not progress past this. Stage 2 would be bilateral hilar adenopathy and reticular opacities. Usually this is upper lobe predominant that you have them. Stage 3 is when you just have the reticular opacities, but actually no hilar adenopathy or it's shrinking down. And then stage 4 is really when you have, I think, fibrotic lung disease. I think classically it's reticular opacities and no hilar adenopathy and then volume loss. But really, this is just pulmonary fibrosis and sort of the most severe form of pulmonary sarcoid that you get.
So speaking of actually treatment, Monty, can you talk a little bit about how we treat pulmonary sarcoid?
Yeah, sure. And I think one point that Firth brought up, worth mentioning, specifically in our case, is that patients that presenting and are given a diagnosis of sarcoid with asymptomatic lymph node involvement generally have self-limited disease and don't actually require treatment. So this could be stage 1 or even stage 2, as Firth mentioned. And some literature supporting that up to 50% of patients with sarcoid fit into this category. So when you're deciding to initiate treatment for someone, you really want to do it to make sure that you're going to be helping with symptom management as well as to protect overall organ function. And as we've talked about, sarcoid can be a multi-system disease and affect various organs. Pulm peeps today, we're thinking more of the lungs, but can affect the eyes, the skin, the brain, as well as the heart, as we talked about earlier. And the key to treatment, though, is really to help with the heightened immune response that's present with sarcoid, as well as to prevent any further granuloma formation. So really the first line agent that I think about and here, and y'all are probably familiar with as well, is systemic corticosteroids. And, I know when we're talking about medications and specifically steroids for anything, something that always comes up is how many mgs per kg per day and what's the taper like. And I think with sarcoid too, there's going to be probably some institutional as well as clinician stylistic differences. But typically, first line agent starting prednisone 20 to 40 milligrams per day. And this can be higher if symptoms are more severe or if there are multiple organs involved. So you may have concurrent cardiac and or pulmonary sarcoid, and I've seen starting doses of up to 60 in those cases. But typically, as I said, 20 to 40 milligrams per day, and this is continued for about 4 to 6 weeks with close follow up and interval assessment of the patient. So definitely getting PFTs, symptom management as well, and you can repeat imaging. So if the patient is doing well in 4 to 6 weeks, I like to think about starting to taper and decreasing by about 5 to 10 milligrams every 1 to 3 months, with the goal to get to about 10 to 15 milligrams a day. And that again is always going to be balanced with interval assessment and follow up. And I think the overall goal is to get to a maintenance dose of about 10 milligrams per day. And this may take up to a year to do. And I know aunts are FERF. I'm not sure if y'all have seen anything different as far as that goes.
No, that's pretty typical. I think, again, I think that different people have slight variations, but at least 6 months, I think of wanting someone like this gentleman who has sort of diffuse disease to be on steroids and then very slowly tapering, monitoring the clinical symptoms, and then sometimes the imaging as well.
So, actually, that's exactly what happens with our patient who started on prednisone and responded really well. He actually did end up going follow up imaging with a PET scan in 3 months that showed that all of sort of the FDG avid pulmonary nodules and the lymphadenopathy that we were seeing was significantly improved. And he was able to be tapered to the maintenance dose of 10 milligrams eventually.
And I think in addition to steroids, definitely that's the first line agent that's used, but you have to think of, what if steroids aren't working, or what if someone is having complications secondary to steroids and can't take them. So some second line agents are really more what we call steroid sparing agents. And three common ones are methotrexate, azathioprine, as well as mycophenolate. And I tend to think of this, these potentially may need to be started if a patient is on greater than 10 milligrams per day for greater than 3 months and cannot tolerate glucocorticoids. And that could be for a variety of reasons, but some common reasons may be hyperglycemia, underlying bone disease, specifically if someone gets a fracture, hypertension or weight gain, um, or fluid buildup. So those are some things that may contraindicate higher doses of corticosteroids. So those are when I start to think about potentially needing a second line agent, as well as if a patient relapses. And the third line agents, which this is really going to involve multidisciplinary care team discussions, are really biologics. So monoclonal antibodies targeted against TNF alpha itself, so such as infliximab and adalimumab. And these are more so used in refractory disease. And again, these are going to be getting a lot of teams involvements about whether or not you should do this as part of a third line agent therapy for refractory disease.
That's such a great summary. And this patient actually was started on prednisone, and I believe is at 40 milligrams, and he had a great response to that and responded really well to that. One point that I want to come back to, Monty, that you mentioned was the utility of PFTs in this patient who had no parenchymal involvement, at least from the chest CT and x ray that we saw. Would you recommend that he gets that outpatient once he's discharged?
Yeah, you definitely want to get PFTs in this patient, and sometimes with sarcoid, you can see different things as we talked about. So you may actually see more of a mixed obstructive as well as restrictive um, finding on PFTs for him, but definitely I would want to get a full set. So including spirometry, lung volumes, and specifically DLCO in someone with sarcoid, and follow those periodically. And then, as Furf mentioned too, repeating imaging as well would be important.
That's awesome. Thank you so much. Wow, what an unusual presentation of sarcoidosis. That was definitely not where I thought this case would be leading. But now it's on my differential for an exudative pleural effusion. One pearl that I'm taking away from this case is serum ACE is of limited utility as a diagnostic test for sarcoids due to its poor sensitivity and can be elevated, as you mentioned, Monty, in many other granulomatous disease. Monty, what's your pearl from this case?
Well, I think I'm definitely going to take Furf's tissue is the issue motto going forward. Um, and I think one important thing is that not all sarcoid requires treatment.
And mine, I think, is always just going back to pleural effusions. New unilateral effusion definitely warrants a tap. And then we use Light's criteria to see if this is transitive and exudate. And then I always say for the first time to get pH, glucose, and a differential. I think that really helps with the diagnosis.
Awesome. Thank you so much for joining us, everyone. We hope you enjoyed this episode.
Thanks, everyone, for joining for another episode of Poem Peeps. Really appreciate it. Come back in 2 weeks for our next episode. This episode was written, recorded, and edited by myself, Christina Montemayor, and Ansa Razak, and the music is original music by Eric